Good morning over to Facebook. Good morning to Instagram. Good morning, everybody. My name is Morgan Denny, and I am ICE's lead faculty for the Primary Care Physical Therapy Division, an online course that we teach. Today we're going to talk about a very engaging topic, hemochromatosis, and kind of dive into a couple of case studies and talk about how that relates to us clinically and if you're going to see that. But first, wait, there's more. Let's talk about a couple courses coming up because there are so freaking many, so I just wanted to make sure that we highlight at least a few. So online, later this week, the management of the modern management of the older adult course online is starting. So if you want to sign up for that, make sure you contact the right people. And then there are courses galore coming up. We've got lumbar spine this weekend in Florida over Halloween. Hope you all wear costumes. And then next weekend, November 7th, there is clinical management of the fitness athlete in New Jersey, total spine thrust manipulation, North Carolina, and modern management of the older adult live course in Delaware. So head over to ice.physio or ptonice.com if you want to check some of those out or courses coming up down the road because there are lots of them. And yeah, get yourself signed up because good stuff in the works. Also, I believe that today is the last day to sign up for Virtual ICE, which is a once a week series where you get to hear lectures from a variety of different faculty and people sort of outside of ICE, bringing a lot of different topics. So if you're like me and you like really short stints of information, so an hour at a time that you can fully digest and that have a lot of variety to them, Vice is a great thing to sign up for. Also, it's pretty inexpensive and pretty quality. So get yourself over and sign up for that. Without further ado, let's talk about hemochromatosis. So for those of you who don't know, hemochromatosis is a disease where basically the person's body doesn't create the right form of iron or the right levels of iron. So normally in the body, what happens is you absorb iron through your intestines. But in hemochromatosis, what happens is you have a faulty gene that kind of signals some of those cells to overly absorb iron. So you end up with really high levels of iron in your body. Now, similar to other types of heavy metals, if you have too much iron in your body, it can become really toxic. This can end up being toxic for your skin, your liver, your heart, your pancreas, your pituitary glands, and your joints. So knowing that, these things can kind of end up in our patients in the clinic, think joints, right? But also can become really toxic for the person overall. And depending on when hemochromatosis is caught and if it's treated early enough, it can have anything from no effects to a lot of effects. And people who have hemochromatosis and end up not having it treated early often have the liver being the most affected with development of liver cancer after developing cirrhosis. And it really is just that buildup of iron in the person's system that they don't know about that can cause that toxic effect in the organs. So this diagnosis is something that is made not just simply by blood tests. Too bad because it would be simpler. It's actually made by looking at transferrin and ferritin levels to see how much saturation is there and to really check on the iron levels. So for patients who are going through this, they may have had blood tests. So if you're talking about screening stuff, making sure to ask specifically about transferrin saturation and the ferritin levels, just to check in on that. So what I wanted to do is share with you a couple of case studies so you could understand how this kind of relates to PT, and we can talk through some of the nitty-gritty. So I actually had a patient that had hemochromatosis probably like 5 or 6 years ago. And to be totally honest, she was a gimme patient, and I'll tell you what I mean by that. So she was a 23-year-old runner who came into PT because she had bilateral hip and low back pain. Beyond that, the real key was this. She had been running 8-minute miles consistently for the last 3 years. Over the last 2 months, what had happened was she had gone from that 8-minute mile down to running a 12-minute mile and being in a lot of pain to where she said she had no joy anymore in running. And it was just like getting herself out there and like slogging through it, but she just didn't feel like she was running and she had all this pain. When I evaluated her hips and her back, she was really stiff. So most 23-year-olds are not super stiff. Like their hips might be a little restricted and they might have some muscle tone, because of weakness patterns or other stuff going on. But her physical joints were very limited. They felt arthritic. So between that and the idea that her energy level had decreased significantly over the previous months, and her running had gone from an 8-minute mile to a 12-minute mile. And for those of you who don't run, that's a dramatic change. It's a very dramatic change. So kind of getting into some of the nitty gritty, I realized that this was probably not just a musculoskeletal thing going on. I didn't know that it was hemochromatosis, but I sent her back to the doctor and said, hey, we're going to keep checking in to work on this joint-related stuff, but I think there's something behind it. Anyway, she came back with the diagnosis of hemochromatosis, and once she started treating it, and as I kept seeing her in PT to kind of address some of that joint pain, it was actually kind of incredible. Like literally her hip joints seemed to change, her back seemed to change. And I'll also tell you, probably somewhat independent of PT, her running also got significantly better, and she felt dramatically better, not just in terms of energy, but also just in terms of her body when she was out there moving. So that's one case that I just wanted to share with you. And I think the takeaway there is remembering that when things don't all match up, when you have a young person who has developed old person hips, or when you have that person and you also have some energy imbalances and you've got a change from kind of their normal activity to where they're at now, it's really key that we look into that and we don't just discount that as like, oh, it's just because of pain. It may not be. It may be a vascular thing. It may be something different. It could be something autoimmune or rheumatic. So kind of having that like your spidey sense that turns on and says like, this isn't a normal case, that can be really key. So one other case study I want to share with you actually was in JAMA a couple months ago in August, I believe. And it was called A Patient with Back Pain and Morning Stiffness. Now, come on. Does that not sound like a patient that walks into the clinic, maybe today? Yeah, absolutely. So I'm just going to read you the first paragraph, right? So a 44-year-old white man presented with 15-year history of dull midline low back pain associated with bilateral hip pain. Totally sounds PT right off the bat. He also noted bilateral hand pain along the metacarpal phalangeal joint and proximal interphalangeal joints and prolonged morning stiffness lasting approximately 45 minutes. Sounds kind of like OA, except this is a 44-year-old. Family history was notable for a brother with osteoarthritis, hypogonadism, and type 2 diabetes. So right off the bat, looking at this case, this is 100% a person that would walk into our door that might present for the low back pain, for the hip pain, and say, I'm having trouble walking, or I'm really stiff in the morning, I just need some stretches. And we might say like, okay, you are stiff, like, yay, let's give you stretches or mobilization or strength or all of the things that we do. But the key here is being able to ask about the other things. And Jeff always talks about this when he's talking about the process. I'm quoting a lot this morning. When he's talking about the process and just kind of understanding that we always check on the other body regions. So this is someone who might walk into the clinic with that bilateral hip and low back pain, and unless we ask any other symptoms, do you have the stiffness elsewhere? Anything in your arms? What about your hands? What about your ankles? All that stuff. We might miss this, because this could be a patient that walks in that's not really concerned about hands and is really thinking, I want you to look at my lower quadrant issues. But this person had the hand symptoms also. Again, we're starting to stack some things up and cluster and say, okay, this human is 44 years old. So why is it that he would necessarily have all these hand symptoms and also have this bilateral hip stuff and back pain? Right? So again, we're kind of like stacking up our ideas to weigh in on all of our hypotheses. So what they did next, because this is a medical case study, not a physical therapy one, vital signs were normal. I will skip through all the numbers, but everything was normal. Blood pressure, respiratory rate, heart rate. They checked SED rate and C-reactive protein levels, which are used to measure kind of general systemic inflammatory levels in the body, and all of those were normal. And I mean, that's usually something where you're like, well, okay, maybe it's not this. But what they did is they did x-rays because they're in hospital. Nice that they can do that. And what they found was this guy had severe degenerative sclerotic changes in bilateral hips, SI joint, a little bit in low back, and in hands. So that's, again, another clue where you're like, there are systemic things going on affecting multiple joints. there's got to be something systemic underlying this unless he had an injury previously to all of those joint areas. So luckily, they were astute in this case study, and they ended up looking at those transferrin saturation and ferritin levels. And that's when they found that they were sky high. So that, again, is the positive test for hemochromatosis. When they get those levels, what they do is they check it against the gene, the faulty gene, HD something or other, HFE something or other. Yeah, I don't remember that part. Anyway, they check it against a specific gene that tells you definitively, yay or nay, this is or isn't hemochromatosis. So once a person is diagnosed with hemochromatosis, basically what they do is they use phlebotomy, right? So they get rid of blood. When your body is storing a significantly high amount of iron, the best thing that they've found to do is to just get rid of a lot of it consistently. And these people actually do really well as long as it's caught early. For some people, they will also do chelation therapy if that idea of getting rid of blood is not feasible for the patient for whatever reason. But usually what they do is just consistent blood draws, just so that they can get that person's iron level lower consistently. So like the patient that I saw, the young woman who was in her early to mid 20s, she was probably one where she'll be on that therapy all her life, but because it was caught early enough, before there was organ damage, before she had heart trouble, before her liver was affected, her issues will probably be fine, and she will probably have a normal life expectancy, normal activity level, normal everything, as long as those iron levels are kept level, right? But for people like in this case study from JAMA, who had already been down the road of 15 years of symptoms and had already developed those osteoarthritic changes, some of those things may never go away, right? So we may have patients that come in like this who aren't so lucky, who have just been dealing with it, as many of us do. I get it, right? Because it's just pain. It's just an ortho thing. It's just MSK, not a big deal, but that start to develop other symptoms, and some of those can be permanent. So it's key for us not only to keep our eyes open to get the person the treatment that they need and the right kind of help, but also because for some of these patients, if they're in our clinic too long, doing 2 sessions a week for 8 to 12 weeks and nothing is changing, it may not be further harm to their musculoskeletal system, but it really could be further harm to the rest of their body that doesn't really respond as well to treatment, right? Like once your liver is going down that road of cirrhosis, you can't just bring it back. Once your pancreas has been overloaded with iron and has become toxic, basically, you can develop diabetes, and that's not necessarily something that's going to go back, right? So some of these deleterious changes we can catch early as PTs. Now, that said, some of the symptoms I read you before were far down the road, right? Like the liver involvement, the heart involvement, the pituitary gland, all of the organ systems. But there's stuff that happens sooner that we are going to see in clinic, and we can catch it a lot earlier. And this is the stuff I feel like is more important to know, right? So people with hemochromatosis on the early side will develop feelings of tiredness or weakness. And I'm just going to take this back to my case study. When I saw that woman, she was not necessarily reporting that she was fatigued all day, but her running was really fatigued, right? That time, her mileage was really going down at a very fast rate that had nothing to do seemingly with pain, but had everything to do with sluggishness. So there's one point in that category. Weight loss is another thing that can happen. I haven't seen that personally. Joint pain. Joint pain is a big one. And again, that's why we as physical therapy professionals, as physical therapists, need to be super aware of this, is because joint pain is one of the main things that we see and treat. People can develop bronze or gray skin, kind of a hyperpigmentation, because the iron is literally building up in their integumentary system. Sometimes they have abdominal pain. Sometimes they'll have loss of sex drive. So these are all kind of questions we can keep in mind when that patient shows up and they're developing, or they have developed some bilateral multi-system, multi-joint pain, and we're feeling through those joints and we're like, these feel stiff, like kind of arthritic, but it's all over the body and it's got that OA morning stiffness presentation. We should be asking some of these questions to kind of screen out, is there something else going on? Is this a blood disorder? Is this something beyond MSK? And I'll tell you honestly, I think that in PT, we often see these more than we know, and we treat them, and they may get somewhat better because their problem is MSK. It's just that the underlying etiology is not. And so I think as PTs, and this is something that we talk about in the primary care physical therapy course a lot, as PTs, we need to get more astute at kind of building up our background knowledge so that when these patients walk in, we don't just like run the course and go through normal treatment and send them on their way and they're better, but they're going to come back or things are going to get worse because we haven't actually asked the right questions. We haven't identified the underlying source. So as PTs, being able to get better at this stuff is one key to getting patients the right kind of treatment and also to making sure that they don't end up back on our schedule over and over until we refer them out and then find out that they could have been getting the treatment they needed sooner. So the flip side of this is if you have someone, it's not really the flip side, if you have someone that does have hemochromatosis, whether it's something that you've caught, right, as a practitioner, the patient walked into your clinic, or whether it's someone who's coming to PT because they have hemochromatosis and developed these joint injuries, right? There are other things that we can do. So beyond doing your normal manual therapy, exercise-based programming, there are other things to keep in mind. So for people with hemochromatosis, really important not only to make sure that they are consistent with their therapy, whether that's right chelation therapy or having those blood draws consistently to stay on top of their iron numbers, but they need to be getting those numbers checked at least once a year. So when you have that patient, make sure you ask them in your screening, oh, I see that you marked hemochromatosis on your medical background sheet. Have you had your annual iron tests this year? You know, just make sure, because if people haven't, or it's been a couple years, they may be sliding in that optimal level and we want to keep them on track. Another thing to ask them is make sure that they're not necessarily taking any vitamins. And I know this sounds really straightforward and like a duh factor is what I would call it, but it's not, right? So making sure that people aren't taking any vitamins because vitamins have iron in them, or they're not taking a vitamin C or vitamin A complex, because those actually will increase the amount of iron building up in your blood as well. So people might not relate that. They might think like, it's just vitamin C, it's supposed to be good for my immune system. It is, but it also is not good for people who have hemochromatosis, right? They also should be advised to make sure that they are decreasing any risk of infection because they are a little bit more susceptible to infection. So that includes things like not eating undercooked meats or fish, being sure to get vaccines is what the medical community would say, just to make sure they don't get that infection. Any strategies really that are sure to fight or prevent an infection going on. Another thing is to make sure that they're not drinking a lot because alcohol use will increase liver damage, and because liver damage is one of the number one things that people with hemochromatosis die from and suffer from, that's to be avoided as well. So again, hemochromatosis, watch out for it, not just because our patients are all going to have it. In fact, its prevalence is debatable. The research says the prevalence actually is anywhere from 1 in 150 people to 1 in 300 to 500 people. So there's quite a debate about what the prevalence actually is, but just so you know, it is much more common in white people. So as you're screening through those factors, if someone's in your clinic and you're like checking the boxes, that's another one to put in there. But making sure that we're thinking about this kind of stuff and getting people the treatment they need is key. And again, in the primary care physical therapy course, this is one of the many things that we talk about in the element of autoimmune disorders, vascular conditions, hematological stuff. So be aware. I hope this helps, and keep that screening going strong because as PTs, as primary care PTs, as direct access PTs, I really feel we need to get better and better at knowing this stuff so that we can get patients the treatment they need. All right, without further ado, the song of the day, which I know you all are waiting for, is It's All Right by the Indigo Girls. See y'all later.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.